you. Okay, some of you guys may have already heard this talk. I don't know. I think I gave it a couple years ago. You heard that, right? Okay. Not very much change. Don't give away the answers. All right. All right, so what do you do when you have kidney issues in a pregnant woman? Don't run the other way and not turn back. They need your help. Okay? Call the nephrologist and get maternal fetal medicine, high-risk medicine on board. Okay. So, normal changes that happen during pregnancy that affect the kidney. That's where we need to start. Okay? Because there's a lot of physiologic changes that go on in the body over that 9-month period when you are pregnant. And how do they affect the kidney? How does kidney disease affect the pregnancy? How does the pregnancy affect kidney disease if they already have kidney disease? What advice do we give patients that are on dialysis or have a kidney transplant if they're thinking about pregnancy? Well, the easy answer for dialysis is most of them are not fertile, but there are a few patients that do get pregnant on dialysis, okay, or develop kidney disease that needs dialysis during pregnancy, okay? And how do we manage the big issue with pregnancy that involves the kidney? Preeclampsia, okay? Anybody here done their OB rotations? That's med school, that's fine. Okay, so we're counting on you guys for this one. I want some input, okay? So, having a pregnancy is almost like having a foreign object, a parasite per se, in your body, changing your whole body anatomically, physiologically, hormonally, okay? As you can see, hormonal changes that affect the kidney. You have increased plasma renin activity because you dilate, blood pressure drops low, renin is turned up. Angiotensin II receptors are then downregulated. Plasma aldosterone goes up, again, similar because of the angiotensin. You have increased prostacyclin because they want to relax the uterus in preparation for this big thing to come out, okay? You have increased thromboxane. I don't know why. That doesn't seem very physiologically adaptive to me, but I'm sure nature has a reason. Okay. And as you can see, that normal uterus, you see how far up it goes by month 9? So guys, when your wives are pregnant, please be understanding. It's not easy. Okay. So, cardiovascular changes. Actually, the heart chamber dilates. So, pregnancy is a risk factor for congestive heart failure. But even in normal pregnancy, you have some dilation and hypertrophy of the heart. So in effect, it's almost like developing a little bit of physiologic CHF, but they maintain the ejection fraction. And in fact, the ejection fraction increases by a lot because now you got to support this other little being there, and they need blood. They're growing. They're very metabolically active. So 30 to 40% increase by stroke volume increase, and also mild increase in heart rate, okay? Vasodilation, progesterone, and the venous capacitance also increases. You develop a whole new venous system to feed this thing called the placenta and the baby, 150% increase, okay? So you can imagine, this is why when you get further along in the pregnancy, you need so much more nutrition to support all of this going on. You're building new blood vessels, building more blood, okay? Blood volume, 40 to 50% increase in your blood volume. So that's like a lot of transfusions. All right, starting at around 6 to 8 weeks, peaking 32 to 34 weeks, so early part of the 3rd trimester. Red blood cell mass also increases, but your blood volume increases more than the red blood cell mass. So when you look at the hemoglobin, actually drops because of that, because it's a relative change, okay? I think I showed you those already. Not only is the uterus affected, but also the bladder and the urogenital anatomy is affected by the hormonal changes. The same things that kind of happen in the uterus are happening in the smooth muscle of the bladder, okay? And because of vasodilation, increased capacitance. You've got a drop in your blood pressure, even though your cardiac output is 40 to 50% higher, okay? So a normal blood pressure during pregnancy in a healthy woman is less than 120/80, okay? In the bladder and the urogenital system itself, the bladder sphincter relaxes. You have compression. There's this huge thing in your belly, and it compresses the bladder, okay? You can have dilation and atony of the renal calyces and ureters, so they actually get a little bit dilated, and they don't move as well. And that's one reason why during pregnancy, women are at higher risk for UTI and for UTI to progress to pyelo, okay? And urinary stasis from all the pressure, okay? Reflux. There can be a little bit more reflux physiologically during pregnancy, but again, it puts you more at risk for developing a UTI. Okay, the function of the kidney changes. Just like your heart is remodeling in effect to have more pump function to support 1.3 people, so is the kidney, okay? So in a normal kidney, every time your heart is pumping, about 1/5 of that blood flow is going into the kidney to be cleaned, okay? And in a normal, healthy, young adult, GFR should be between 90 to 120, 130 mLs per minute per 1.73 meters squared, okay? And usually the filters of the kidney do a very good job in reclaiming things that it needs, like blood cells and protein, especially that albumin protein, because of the negative charge and because of the size of the openings on the membrane, the slit pore. So usually you will not detect, it will be undetectable on your regular dipstick. If you had a specific measure, it would be less than 20 milligrams of albumin spilling out over a day, okay? And normal serum creatinine in a young woman who is not pregnant should be anywhere between 0.6 and 1.1. Okay, so these things change with pregnancy. These are normal changes you see with pregnancy. The kidney, like the heart, is overworking and hyperfilters 50 to 60%. Okay, just like the heart is picking up, so is the kidney. The glomerular filtration rate increases by 150% by the end of the first trimester. Okay, so you see increased clearance of BUN, increased clearance of urate, increased clearance of creatinine. All of those levels are going to naturally drop down. Okay, so a normal creatinine in a non-pregnant woman, 0.6 to 1.2. A normal creatinine in a pregnant woman should be less than 0.7 always. Okay, if you're seeing a 0.9, a 1, a 1.2 serum creatinine, which we all think of as normal, in a pregnant woman, that is not normal. That is renal insufficiency. Okay. There's hyperfiltration of other things, glucose and protein. So a pregnant woman can have a normal or physiologic spilling of protein up to 300 milligrams a day. Okay, and they can have anywhere from 1 to 10 grams of glucose spilling in the urine. It's a lot. So probably why they pee a lot too. Yes. By week 13, they have increased, so, by the end of the first trimester, you're going to see those changes. Okay? Okay. A few other things you may not really. Sodium filtration is also increased because you have increased renin and aldosterone. Okay? And then you get fluid retention. You see that especially towards the third trimester, okay? And the blood pressure can drop as much as 10 points from their baseline level, which we would expect. So if they're not having a physiologic drop, that can be a little bit not normal. And that happens in the first 2 trimesters. By the time you get to the third trimester, then the blood pressure starts to slowly increase closer to normal range by the end of the pregnancy. Okay? But again, normal blood pressure should be less than or equal to 120/80, so the same as our normal definition in a regular person. All right. Here's a patient. That's not really their name. 18-year-old young lady, Hispanic, comes into her OB, her regular OB. She is in her third trimester, 32 weeks. She's got some mild back pain and is complaining of some pitting edema all the way up to the knees, but she says, I'm feeling okay except for this back pain. A week ago, you treated her for a UTI. So you check her vitals, get her temperature, you say, oh, let me check a UA on you, and you check her labs. And what is notable about, somebody comment on those, anybody? Okay, she's febrile. What else? Blood pressure is a little bit high for pregnancy, right? Okay. Speak up, I can't hear you. 2+ protein in her urine. So one thing to when you're during pregnancy, when you're doing protein assessment, a spot protein creatinine, if it's high, it makes you want to check it. Don't count on those because they're notoriously unreliable. So if you're seeing protein in the dipstick persistently, get a 24-hour urine. Okay, that's the only really reliable way to quantify proteinuria in a pregnant woman. Good. What else? What's that? She has pyuria. That's right. And no bacteria, at least on the microscopic. Anything else? What about the creatinine? That is not a normal creatinine for a pregnant woman. Okay, so you've got a young woman, third month of pregnancy, about 32 weeks, coming in with back pain, fever, little elevation in blood pressure, and a little bit of mild renal insufficiency with bacteriuria. What do you think this lady has? Pyelo, definitely. Number 1 on your differential is going to be pyelo. Okay? And you say, well, let me get a kidney ultrasound on you. These are the findings, and you say, let me send another urine culture, and I'm going to put her on some Rocephin. Let me admit you and put you on Rocephin. If they have pyelo, they should be admitted if they're pregnant. If they just have a UTI, you can manage that. But again, pyelo, they're high risk of not doing well, so those patients should be admitted to the hospital for management. Okay? Whereas in normal, healthy young women who have a pyelo, unless they're septic, you can treat that as an outpatient. Okay? So here's their kidney ultrasound, and what do you think of that kidney ultrasound, by the way? Shout it out. I won't identify you by name, because I'm terrible at names. The kidneys are big. Very good. Because how big was this lady? 50 kilos. Okay? In a 50-kilo lady, maybe a little bit taller than me, you should expect the kidney sizes to be closer to what? Maybe 9.5 centimeters, okay? But what about during pregnancy? Do they change during pregnancy? They hyperfilter, and just like diabetics who hyperfilter, they probably could get a little bit bigger, but from 9 to 14.5, that's a big change. So what do you think is causing that? Somebody said something. Hydronephrosis, and indeed, what it says, there's some mild bilateral hydronephrosis, and just to kind of, for people who look at these a lot, when they say mild hydronephrosis, sometimes that's an overcall, sometimes it's an undercall. It really depends on the radiologist reading it. Okay. She was 32 weeks. You can. Remember, they dilate. Actually, the calyces dilate. There's atony. They're actually, in pregnancy at 30 so many weeks and there's pressure on the bladder, there can be a little mild, that was a red herring. That was very smart of you. You picked up on it. So I was going to say, jump on the hydronephrosis. Mild hydronephrosis, which could be pelvic ileectasis, which is very minimal in pregnancy. I wouldn't, attribute too much to that alone unless you had other things going on. Because even just physiologically, they can have a little bit of mild hydronephrosis. If you ultrasounded every woman's kidneys when they were at that age, you'd probably find a fair number of them. Most of them have a mild hydronephrosis, okay? But if it was moderate hydronephrosis, what would you want to look for this patient? Obstruction, okay, which they can have, and we'll talk about that a little further down. But what are the things that people can have obstruction with? Hydronephrosis, fever, back pain, pyuria, kidney stones, right. And then this patient oh, sorry. Oh, darn, it didn't work. I was going to get the little differential, so you guys did very well. Her urine culture came back, and actually there was no growth, and you thought, well, maybe it's just, not treated. You continued to treat her. Her kidney function got worse. She actually had AIN. Remember, she was treated a week ago. She was allergic to Bactrim. She got treated with Rocephin. She apparently was allergic to Rocephin, had AIN, and then once you stopped you restarted her again on Rocephin, because it's a good medicine for UTI in pregnant women. You stopped it. It still got worse. She got 5 days of steroids, and in fact, she got better. So just normal causes for kidney function also can happen, not just pregnancy-related causes, but of course, think of the pregnancy-related causes first. Okay. We have recently had a talk from Dr. Livingston, the maternal fetal medicine guy. I wasn't there. It was very sad. I cried. I didn't cry. But I supplemented my talk with some of the things that he taught us, okay? So pregnancy-specific causes, and in fact, another cause of obstruction is this odd thing called uterine incarceration. Put that uterus in jail. But anyway, apparently it happens during the second trimester and you get urethral obstruction. That is all I know. Anybody in OB know more what that is? Okay. I missed the talk, so I can't tell you any more about that. Pre-renal, okay, second trimester, emesis, nausea, vomiting. Some people have it really, really bad, and they can't keep up with it, and they can have some pre-renal. If it's persistent, it could go to APN. Septic abortion. I think we're doing pretty well here in the States, but if you're in a rural community or in a inner city area, or you're not here in the States, that's still a very high cause of mortality, in fact, but also kidney failure from sepsis, okay? UTIs, higher incidence of complication with UTIs, higher incidence of stones or other causes of obstruction. I think we had a woman who we were consulted to see who had, I think, ovarian cancer and some hydro because it had spread and it was obstructing her ureter, and she was pregnant. Anyway, so you could see all sorts of things. ATN, common things being common, prerenal, AIN, preeclampsia later on in pregnancy can cause renal failure or new renal failure. You could see primary glomerular disease. Actually, lupus tends to flare more during pregnancy, okay? So don't short count that. And this thing called TMA, you'll rarely ever see that, and it's hard to differentiate. Okay. So you guys got all the important points. Okay, so I put the slide later. All right. New onset GN. Not as likely, but they could come in with pyuria, fever. Not as likely, but if all things were negative, you might think that. Probably not. Okay. Okay. You are the OB, or you're the OB student or resident for the day, and you have a young woman who comes in. She's 28. She wants to get pregnant and have a baby before she gets too much older. She used to see a kidney doctor when she was diagnosed as a 14-year-old with this funny thing called IgA nephropathy. And she said, oh yeah, they biopsied me and they told me I had IgA nephropathy, and I don't really have good kidney function, but I haven't been to see my doc. But I'm taking medicine for hypertension, and I don't use NSAIDs because they told me I shouldn't use NSAIDs. She comes in and she wants to know, I want to get pregnant. How are you going to advise her? So again, you're going to see that, when is the highest likelihood of lupus? Young women of childbearing age, okay? And so you're going to see this. And in fact, we're seeing a lot of people now with renal insufficiency young from metabolic syndrome, obesity-induced FSGS. How are you going to advise those patients, okay? So she's not very well controlled, this young lady, even though she's taking her medicine. She's got hypertensive, she's got some edema, she's got some activity of her disease. Her creatinine is 2.1. Anyway, she's anemic. All right, so here are some of the considerations, okay? It's not kidney disease specific aside from lupus. Lupus, we tend to, it's a little bit off on its own, okay? But even with lupus, some of these things apply. So it doesn't matter if it's IgA nephropathy, if it's FSGS, if it was obstructive disease that caused kidney failure because they had UPJ, as a child. It's not the type of disease, but it's rather the degree of baseline renal dysfunction that is going to be the key characteristic, okay? And the degree of renal dysfunction, the higher the degree of renal dysfunction is associated and predictive of worse outcomes, both for the mother and for the fetus, okay? And on top of that, aside from kidney dysfunction, poor control of hypertension and a high degree of proteinuria. I mean, it makes sense. Bad kidney disease, badly controlled, bad for pregnancy, okay? A much higher rate of preeclampsia in women who have CKD compared to women who do not have CKD. And there's a high risk of worsening, also the effect of pregnancy on kidney disease, of worsening of kidney function, okay? 30 to 50% in some studies. And that depends really on the degree of renal dysfunction. Okay, so we need probably some more data. This is an old paper, but this is still where we really this is a very good study that was done back in 1996. And they looked at severity of underlying renal disease, and they tried to find what is the inflection point, okay? So I don't think I would call serum creatinine of 1.4 in a pregnant woman minimal, or a non-pregnant woman minimal. I'd say that's probably moderate. But anyway, this is how they classified it, okay? So if your creatinine is less than 1.4 and you are well managed, you don't have hypertension and your proteinuria is well managed, you probably could get through pregnancy pretty well and do okay, and you can maintain stable kidney function, okay? If you're between 1.4 and 2, 1.5 to 2, there's about a third of chance of progressive renal dysfunction. I told you wrong, sorry. Less than 10% chance, but between minimal to 10%. If your serum creatinine is greater than 2, it's greater than a third of chance that you're going to progress and have worsening kidney function. And some numbers up to 50%. Okay? And also with CKD, there's more risk to the fetus, intrauterine growth retardation, preterm delivery, preeclampsia, which then conveys mortality both to mom and baby. There was one study that showed that uncontrolled hypertension was a risk factor, but the mortality, it's very variable, so I don't know what to make of that study. The higher risk of fetal loss, the more advanced your kidney disease is. I think that's a pretty good study. Okay. I'm just going to skip this because I don't think we have time to go through the whole thing. We've sort of already touched on all of that. Lupus, any patient that is on immunosuppression, you need to look at what kind of immunosuppression is. It may need to be modified if it's fetotoxic, okay? Myfortic, which is an anti-proliferative, not very good for fetus with proliferating cells, okay? So they cannot be on myfortic. They need to go back on the old therapy, azathioprine. Prednisone should be fine. Cytoxan, which attacks, it cross-links DNA, not a healthy thing for developing fetus. Please don't use that. Okay, how about again, I might skip this because transplants probably will see them mostly in the kidney clinic, but you can get pregnant after having a kidney transplant. Fertility returns. We have a lot of young women who get kidney transplants because they had childhood kidney disease, and they want to know, can I get pregnant? You can, but we don't recommend getting pregnant until they have 1 year at least of stable transplant function, because pregnancy there's increased risks both to mom and baby during pregnancy, okay? And again, her immunosuppression medication will need to be adjusted. Okay, so let me just go through that. Okay, so in terms of pregnancy with chronic kidney disease, if renal function is minimal, as long as they're monitored to make sure that they're well controlled and they don't have uncontrolled hypertension and proteinuria, probably they're fine. They just need to be watched closely, and as they get further along, they'll go into the high-risk clinic and be seen both by nephrology and the maternal fetal medicine guys. Okay? Mild to moderate, most likely they can proceed with pregnancy with precautions. Okay? But you have to just discuss that, they could have a little bit higher risk, and especially preeclampsia, I think, is the big risk. Okay? Because underlying chronic kidney disease, pre-existing hypertension, those are all risk factors for preeclampsia. They may have a little earlier, preterm delivery is a little bit more, okay? Intrauterine growth retardation, so they need to watch for those things a little closer. And if their creatinine is greater than 2, we usually really try to counsel them against that, because we have had people that progress to kidney failure, and it's very hard to get them through a pregnancy with kidney failure. They need to be admitted to the hospital and have near daily dialysis until they deliver the baby. And then they're on dialysis, so it's not a very, easy thing. But sometimes we do that because, women want to have babies, and to them that is more important. So we do manage those in the hospital. Okay. I'm just going to, okay, so you're going to see, okay, 41-year-old, never had a baby, wants to have a baby. So already she has advanced maternal age, yes, is a risk factor. And she went to get some in vitro fertilization, and now she has twins. And she's very happy, but she is one of those obese women, and she's been a smoker for 20 years, unfortunately, but she stopped because now she's pregnant. She's 32 weeks, and she's coming in to be evaluated. She has a blood pressure of 145/98, protein creatinine ratio of 1.7, and then for some reason she didn't get admitted to the hospital. I don't know why. I guess they were going to bring her back to get checked, and she didn't come, and then 5 days later she presents to the ED, severe headache, right upper quadrant pain. Now her blood pressure is 165/108, platelet count is 70, creatinine of 1.3, elevated AST and ALT. What does she have? HELP syndrome. What is the therapy for this woman? Deliver her. And thankfully she's already at 32 weeks. Give her some steroids, call the OB, get the labor delivery room ready, and get that baby out. Okay. So what of those things are true? I'll just take a group census. Okay, risk factors for preeclampsia include primigavida status, yes or no? Yes. Advanced maternal age, yes. Multiple gestations prior, yes. Cigarette smoking and obesity. Actually, cigarette smoking does not, and I cannot explain that, and please don't pass that around. Still bad, but obesity is. That's the only one thing. Every other thing is a risk factor for preeclampsia. It doesn't make sense to me at all, because preeclampsia we think is a vascular disorder. Endothelial dysfunction and smoking causes the same, so maybe those studies were wrong. I don't know. Okay, and the definitive treatment for HELP syndrome, delivery, okay? Because not only is it a high likelihood for maternal seizure and death, it's also a high likelihood for fetal death. And if the fetus is already 32 weeks, you know, that's a survivable age, okay? How about this statement? Preeclampsia most likely would have been averted with low-dose aspirin and calcium supplementation. No, there's really no, just like acute, what is this with acute kidney injury, renal, there's no known therapy to prevent preeclampsia, except I guess not to get pregnant. Okay. All right. Sometimes if you have APA syndrome in a lupus patient, you probably should be on aspirin, okay? Okay, so hypertension, this is the biggest thing you're seeing, this will be the last. Okay, so hypertension during pregnancy, it's pretty common. 12 to 22% So almost a fifth to quarter in some studies of all pregnancies can have hypertension at some stage. And it's important to know how to classify it, okay? So there's some broad categories. Chronic hypertension, you're going to know that because they came in with hypertension, or if they didn't have prenatal care and they came in and they're before 20 weeks, we call that chronic or pre-existing hypertension, okay? Preeclampsia, we're going to talk about how you separate that. Preeclampsia superimposed on chronic hypertension, because we know chronic hypertension is a risk factor for preeclampsia. And then gestational hypertension, which we call that new onset hypertension during pregnancy without preeclampsia. Okay, so how do you separate those things? 20 weeks. Prior to 20 weeks cannot be preeclampsia if onset was prior to 20 weeks. Onset prior to 20 weeks is chronic. After 20 weeks, it could be preeclampsia, it could be gestational hypertension. It could also be chronic hypertension that's gotten worse, but they should have some history. I know sometimes you don't know those, okay? So how do you separate preeclampsia from gestational hypertension? Preeclampsia is defined not just by elevated blood pressure, and the blood pressure should be elevated on multiple readings at different times above 140 over 90 or above, okay? And also you would see, so elevated blood pressure plus proteinuria, more than the 300 milligrams per day, okay? Increasing proteinuria, plus or minus renal dysfunction, okay? So 20 weeks, onset at 20 weeks or later, hypertension persistent above 140 over 90, at or above, increasing proteinuria, plus or minus renal dysfunction, that is preeclampsia, okay? Gestational hypertension is hypertension that's above 140 over 90, but without increasing proteinuria or renal dysfunction, and it goes away after they deliver, okay? And then superimposed, the blood pressure gets worse. You have a 30 millimeter increase from the baseline blood pressure. You have progressive proteinuria, because sometimes they come in already with CKD and some proteinuria, but it's getting worse, okay? Or you have worsening renal function or development of HELLP syndrome, okay? All right, so again, definition of preeclampsia. And we sometimes can see preeclampsia developing even after they deliver. So even though that's the definitive therapy, sometimes they can have retained retained placental products, and those vessels that are retained could still trigger preeclampsia. Some people have seized after they deliver, okay? All right, a little bit of data, demographics. Worldwide, 7 to 10%, it's a big, big problem. Leading cause of maternal and fetal morbidity and mortality worldwide, okay? If it's mild and the onset is after 36 weeks, that's usually not too bad, because that fetus can probably survive and they could be delivered if that needs to be, and you can, if they're mild, you can expectantly manage them and still get them a little bit closer to delivery, normal delivery age. If it's developing before 33 weeks, why 33 weeks? Why 33 weeks? Fetal lung maturity, okay? Because that's really the thing that determines how well the fetus is going to do, the main determinant. And if you want to, promote that, give them some steroids. Any woman that comes in that hasn't yet gotten steroids for fetal lung maturity who has preeclampsia, they need to go ahead and get that, okay? 15 to 20% of all maternal mortality in a developing country is preeclampsia or eclampsia. And this was reported, and I can't substantiate that data, but so that the 8-fold increase actually in maternal mortality if they had severe preeclampsia, and that was sometime after delivery. So it wasn't in the immediate setting, but following. So they can have long-term mortality, increased risk. Okay, how about for the fetus? 15 to 57% increase in preterm delivery. Yikes. Growth restriction, 10 to 25% increase. Death with delivery, if you're before 23 weeks is kind of the cutoff, okay? And why 23 weeks? because it's what we consider the minimal age of fetal viability, right? And in fact, you can't have an abortion after 23 weeks, is that correct? Is that just like not legal anymore, or you have to deliver? Is that just North Carolina? So what is it in North Carolina? 20? Okay. Having worked in the neonatal ICU with Sheldon Coronis, who's a big ICU guy in Tennessee, I'm going to tell you that those 19, they're never going to make it. 22, very, very small chance that they might make it through. We have had a few of those that came out of the NICU after having spent many, many months there, ending up with a trach, sometimes with a G-tube, neurologic problems. I don't recommend that. I don't think that's really good for the kid unless we can do it better, okay? 23 to 24, a few more of those make it through, and sometimes they do okay by the time they get to 3, 4, 5, but they have growth issues, they have learning issues, they have long-term chronic issues, they have behavioral issues. So again, difficult, okay? So 22 to 24 weeks, again, high fetal death because it's just not good survivability age. All right, and premature delivery, that also has increased risk. And long-term for these kids, when they grow up, they also have increased cardiovascular risk, okay? All right, we went through that already. Again, just some caveats. Sometimes the criteria is not so clear if you have things that are muddying the picture, okay? If you have progressive renal dysfunction before 20 weeks, what do you do for this person? They have kidney failure and it's worsening and it's prior to 20 weeks. They're not you've treated them for pre-renal, they don't have an antibiotic exposure. What do you do for this person? Is this new onset GN? Is this RPGN? Sometimes we biopsy, okay? It's a high-risk endeavor, but I mean, kidney failure during pregnancy is not good for mom or baby, and if it was GN, we at least could treat them with steroids and maybe azathioprine, okay? So sometimes we have that situation. A lot of times if they have renal dysfunction that's new, but it stabilizes, we may just temporize and do the biopsy after pregnancy, especially if they're close enough to, you know, that we think that they've got some time and we can get them through without kidney failure. Sometimes we don't have a choice. They're high risk. They end up on ESRD. We dialyze them. They do or they do not get through pregnancy, and then they get biopsied afterwards. Okay. And in fact, I read this criteria and I'm like, oh my God, how are we supposed to know? 10 to 15% of women who develop HELP actually don't have hypertension and proteinuria. I don't know what to do for that. You can't, there's nothing you can do except treat it once you see it. Okay, so there's some things that they're studying to try to predict whether they're going to develop preeclampsia, if it's going to be severe. This is a potential early marker for severe preeclampsia, but again, needs more study. Same thing here. Okay, just some of the things that we think. So, how does pathophysiology behind it? Endothelial dysfunction leading to some kind of inflammatory response. They also feel like there may be some immune maladaptation. I couldn't describe that really further, except that they think it's something to do with the fetus and the dad's genetics not happy with mom's genetics. Abnormal blood vessel development during placentation, when that whole venous circulation is developing to support the baby, and that leads to, along with endothelial dysfunction, reduced placental perfusion, vasoconstriction, hypertension, poor flow to the baby sometimes. So, and then what are the clinical things that you can see? Well, the signs and symptoms, neurologic signs and symptoms, nausea, vomiting, headache, confusion. Those are very dangerous symptoms, okay? Next thing you know, they have cerebral edema, seizure, death, okay? Liver necrosis, again, these are all delivery criteria. Maternal hypertension in the kidney, what we end up seeing in the cases that we have kidney tissue, glomerular endotheliosis, which is inflammation and kind of thickening, edema, proteinuria, renal dysfunction. We can see a lot of different pathology, like FSGS sometimes. Fetal intrauterine growth retardation in preterm delivery, hypoxic injury with subsequent hypoxic issues, neurologic, developmental, school behavior issues, perinatal death. Okay, so placentation. Normal placentation starts around 10 to 12 weeks, is usually complete by 20 weeks. So something about that 20-week mark. I don't know. And there's this thing called pseudovasculogenesis, if you guys recall back to pregnancy and OBGYN, where it's the different layers of the placenta. So the cytotrophoblasts, they actually invade. You see, it's very parasitic. They invade into the maternal arteries and steal away some of the circulation for themselves. Sorry, I think pregnancy is a wonderful thing, but pathophysiologically it is very, All right, so speaks somebody with a scientific mind. Okay, so we think there are different stages: poor placentation, impaired pseudovasculogenesis, and that leads to oxidative stress, some anti-angiogenic, so that blood vessels are not forming correctly. There's some kind of inflammation that's maybe related to endothelial dysfunction, and then you have a systemic inflammatory response, and somehow that is driving hypertension and all this dysfunction. Okay. So if it's mild preeclampsia, you can expectantly manage them, especially if they're close to delivery age. So again, that 23 weeks of age, if they're before 23 weeks, that's going to be difficult. If they have more progressed preeclampsia, they have severe preeclampsia, and you do expectant management, you're probably only going to gain like a week or 10 days. So just think about that. If you're at 23 weeks, 1 week later is 24 weeks. So 24 weeks is the probable time that fetus will be delivered. Okay? So you just have to, these are things you have to keep in mind when you're counseling the parent. Okay, so close, they need to be admitted to the hospital, they need to have bed rest, they need to be monitored very closely so that you can catch them if they're starting to progress. You can manage the hypertension. Steroids again. The goal is to balance fetal survivability with maternal and fetal morbidity. Okay? Blood pressure control, low salt, fluid restriction. Alpha agonists are commonly used, methodopa, aldomet, clonidine sometimes. Alpha beta blockade, actually metoprolol pure beta blockade is usually not recommended, though we have had some patients on that because it can cause some more fetal ischemia. Okay? Diuretics sometimes can be used with caution if they're very edematives. But again, hypovolemia, intravascular contraction with poor perfusion of the placenta can be a risk factor or a complication. Calcium channel blockers. No ACE inhibitors. Okay, they used to say no ACE inhibitors just in the 3rd trimester, but now we know that even in the 1st and 2nd trimester it can lead to fetal abnormalities. Do not tell them it's okay to take it. We still, to this date, are having people coming in on ACE inhibitors in their last trimester. Again, same thing with ARB, nitroprusside, we want to stay away from that, okay, and metoprolol, probably should stay away from that if you can, okay? Again, HELP, that's what that stands for, hemolysis, elevated liver enzymes, low platelet count. I should have asked you guys that. Severe preeclampsia if you have HELP, if your blood pressure is stage 2, 160 over 100 or above, or if you had chronic hypertension and you're all of a sudden seeing a sudden rise, 30 millimeters of mercury or more above where you came in, proteinuria of more than 5 grams a day, renal dysfunction, any CNS symptoms really should be delivery, okay? Or fetal distress is also the other indication for delivery. And then these are the really bad things that can happen. DIC, pulmonary edema, seizure, usually leading to death, okay? This side kind of from Dr. Livingston, where he says it is possible in some cases to manage severe preeclampsia expectantly, and these are the criteria he kind of gave. So if you have chronic hypertension with superimposed preeclampsia, it's the same as severe preeclampsia, okay? They should be treated as the same category. If you're mild preeclampsia, expectantly manage them until they get to around 32, 34 weeks. Give them the antenatal steroids. If they're having problems or signs of progression, you could potentially deliver at between 32 and 34 weeks and have good fetal outcome, okay? If they're 23 weeks or less, we really should counsel termination so that, that we don't have 2 deaths on our hands, okay? If they're between 23 and 23, again, very chancy there, and 33 weeks, you can try expectant management. And then if they're worsening, then you need to go to delivery. If you can get them closer to that 32 weeks, then they should just be delivered so that they don't, get worse. If they're 23 weeks or more and they have help, deliver, okay? We just had a consult in the hospital when I was on service. Older maternal age, advanced maternal age, has 4 prior pregnancies, 2 prior pregnancies affected with preeclampsia. So prior preeclampsia is a risk factor for preeclampsia, okay? Chronic hypertension, and she did not have chronic kidney disease. Came in and she was 22.3 weeks or something like that. And I got called down there, and her blood pressures for hypertension, and her blood pressures were 170s, 180s to 200, over 110 to 120, where her baseline was like 160s. She had gone from like less than 250 milligrams of protein to about 3 grams. And I got called down there, and they're like, why are we still expectantly managing this lady? You should counsel her for termination. Well, unfortunately, she did not want to terminate, and then she left the hospital ANA. So we want to try to stay away from those cases, but you will see them, okay? All right. Any questions? She might have died. I don't know. Is anybody on OB currently? I don't know if she ever came back. She left the hospital. Her blood pressure was still uncontrolled. I don't know if that lady is still alive. Thank you, guys. Oops. Tied to the...